Hey everyone, welcome to the Happy Flosser podcast. My name is Billy Luntz. I am your host, and I'm here to talk to you about all things dental hygiene to support you through your journey through the dental hygiene program. It's really great to be with you today. Today's topic is about orthodontic care. And as a clinical dental hygienist, you will be evaluating the occlusion of your patient as part of the assessment process. And there's lots of things that you need to be thinking about based on the risk factors of your patient, and you'll have to be charged with educating your patient on the different types of orthodontic appliances that they may need, the need for treatment as far as why somebody might need ortho, what constitutes a need for ortho, some of the things like that. So as you're doing your assessment on your patient, and in school, you'll definitely have to learn about occlusion, right? And I do cover a couple of episodes on occlusion. So when we're talking about orthodontics, we're talking about looking at conditions that involve things like irregularities of the teeth, different profiles of the face that may be off a little bit, the jaw function, and how those things influence the physical and mental health of our patients. And if you think about what the goal is of having orthodontic treatment for a patient, it brings back the form and function, right? It maintains or establishes form and function to the dentition. It also improves confidence, good facial aesthetics, promotes really long-term stability of the periodontium, reduces the caries risk. It really puts the jaw joint in the happiest place that it can be, and it establishes really good long-term health. It's easier for a patient to maintain their dentition when they have form and function in place. Like all of the contact points are good, there's no malpositioning of the teeth, and all of those things. As far as consideration goes, it really goes a long way at helping the patient over the long term of their teeth health. There are different things that cause malocclusion, which is defined as any deviation from a normal relationship. And that can be inter-arch relationship, so tooth to tooth, or it can be opposing arch malocclusion, how the two arches come together and relate with one another. And there can be genetic discrepancies for malocclusion, like congenitally missing teeth, or there could be trauma induced malocclusion, something like a fractured bone or tooth displacement or parafunctional habits like tongue thrust or thumb sucking, something like that. So we look for things in the assessment to help give us an idea of what the treatment plan should be for a patient. And we kind of do an assessment as far as what is their occlusion, what is their malocclusion in their transverse plane or their occlusal plane. And we look for things that give us key indicators of a need to refer that patient. When we look at the patient's occlusion, we're looking at things like crossbites and things that are out of alignment. We're looking at the curve of Spee. We're looking at the curve of Wilson. All of these different things play a role in correctly identifying if somebody needs orthodontic therapy. We look at the patient's medical history, their intraoral and extraoral exam. We take photographs, we do radiographs, and then when either we would take impressions or 3D images to help us identify the patient's need for orthodontic treatment. So as a dental hygienist, some of the things that you might look for on the medical history, is this patient taking any medication that may cause gingival hyperplasia, like an anti-seizure drug or something? That's going to play a role as to whether or not this is a good patient for orthodontic treatment. Is the patient on bisphosphonates, right? That slows down cell turnover. So that would also be a contraindication for ortho. Is the patient a mouth breather, right? Do they have a higher palatal vault? Posterior crossbite typically happens with this, or they might have overjet, a significant incidence of overjet. These are the things that we're looking at in the medical history to help us make a proper assessment of the patient's need for occlusal intervention, like of braces. So it's really important when we're doing our intraoral and extraoral assessment to look at the primary and permanent tooth eruption patterns. We also take a peek at that primate space. We look at the process in tooth development where the teeth enter the mouth and become visible. That should be evaluated for perhaps your patient has an altered sequence. It's not necessarily about the eruption pattern, but it's about the sequence. Maybe somebody's a little bit late to the party on their eruption. That doesn't necessarily matter as much as the sequence, as long as the sequence of how the teeth are supposed to come in correctly. And then it's very common for us to take photographs of our patients so that we can evaluate them over time. And what that would consist of is an image of the maxillary arch, an image of the mandibular arch, an image of just the front of the face in the arch, and then a lateral view, almost like a bite-wake photograph of the left and right side to really show how the teeth relate to one another in the two arches, and then also how the teeth relate together, their marginal ridges. Are there any marginal ridge discrepancies across the arch itself? And oftentimes we take a panoramic radiograph, and that is used to examine the structures for the presence of pathology, or for something like a supernumerary tooth, a congenitally missing tooth, or an impacted tooth. And then another radiograph that we'll commonly use in the assessment process to determine orthodontic need is a lateral cephalometric radiograph. And that's really used to assess the facial and jaw proportions and the skeletal relationship of the jaw to each other. It's also used to determine the need to reposition those anterior teeth because it gives you that side profile. And then one other radiograph that's commonly used is a CBCT, a cone beam computerized tomography. It's a special type of x-ray used when a regular dental or facial x-ray is not sufficient enough to give you all of the information that you need. And then depending on where you work, you would take impressions and do a study cast model, or you would use something like a 3D iTero scanner to provide yourself with optical scanning. And optical scanning takes like thousands of pictures per second. There's no messy impressions, and it gives you as the clinician a real-time visualization of what's going on in that patient. You can check the coverage and accuracy right there chairside as you're doing it. It's pretty great. A couple of things you want to keep in mind when you're thinking about evaluating your patient for the need for ortho, because these are our kiddos, like our, 5 to 18-year-olds. It's important for you to know the difference between a couple of different ages. Developmental ages, you start with the skeletal age of your patient. The skeletal age is the development of the skeletal system. That is the skeletal age. The dental age refers to the maturation of the teeth, including clinical eruption. That can tell you the dental age of that patient. And then the chronological age is the age in years and months. And this is really important when you're evaluating for ortho. The correlation between these three factors, the skeletal age, the dental age, and the chronological age, is assessed when you're planning out orthodontic treatment. Because remember, the occlusion depends not only on the eruption, the shift, and the position of the teeth, but also on the skeletal growth of the mandible and the maxillary arch. If you think about that mixed dentition phase, that adolescent stage, there is so much growth that occurs during that time. The timing of the orthodontic treatment during adolescence, it should really be planned carefully to really take advantage of that rapid growth that occurs in the dentition and in the arches for these patients. So the other thing I just want you to keep in mind is that even though you learn the eruption sequence and the eruption patterns, and you have to learn the eruption dates for all of your patients for their teeth, there are some things that you want to keep in mind about your patient as you're kind of trotting along through the evaluation phase. That is any kind of alteration that occurs in the sequence. That could be anything from holding onto a primary tooth too long, having a congenitally missing tooth, not having the leeway space for the eruption of the permanent premolars, finding out that your patient has impacted canines, discovering that your patient has lingual eruption of their permanent anterior teeth, noting that your patient might have a midline diastema, or if there's crowding present on those mandibular incisors already, or maybe your patient loses their primary teeth a little on the early side. The sequence of eruption is more important for you to focus on than the exact timing of the eruption sequence. An abnormal sequence could indicate that there's some kind of developmental or space-related issue. So just keep that in mind, that late eruption isn't necessarily a concern if the sequence is in its normal trajectory. If we're starting with the mandibular centrals, and then we get the maxillary centrals, and then we get the mandibular laterals, and then we get the maxillary laterals, and all that's going on while the permanent first molars are coming in, and then kind of things take a little break, and then we lose the premolars, and then the canines are the last to come in just before those second molars arrive. Everything is going normal as far as the sequence, but maybe this is happening a little earlier for your patient, or maybe it's happening a little later for the patient. As long as the eruption sequence itself is not out of sorts, then it's not much of a concern. It really isn't. And sometimes parents will ask you these types of things. As a general rule, a permanent tooth should erupt when about 3/4 of its root has formed. And you'll see that on the radiographs. Premature or delayed eruption may signal an eruption disturbance. My 13-year-old daughter, is currently in ortho, and we noticed an idiosyncrasy. We noticed a problem with her sequence pattern. She still had her primary canines, and she still had her lower left second primary molar. And then when we took the Panorex to do the assessment on her, it was discovered that she had two things going on. She had impacted maxillary canines, and she had a congenitally missing mandibular second premolar. Those were the things that related to the interruption in the sequencing pattern. So that's just an example for you to see how, as soon as there's an interruption in the proper sequence of the eruption dates, something might be going on, and you've got to take a closer look during your assessment. When we have a congenitally missing tooth, so there's no successor, there's nothing pushing on that primary tooth to be exfoliated. So this happens a lot in the mandibular second premolars and the maxillary lateral incisors. And this can really affect the spacing and the symmetry of your patient's smile. And then the same is true, just like holding on or retaining a primary tooth, the same is true when a patient loses a primary tooth early. Right? If they lose it at least 6 months before its expected eruption, there can be mesial drift of the adjacent teeth and kind of lock in the permanent tooth. All of a sudden there can be crowding and space can be lost. So the adjacent teeth can kind of invade the space that is supposed to be held for that successor. And that can lead to some early malocclusion issues. Now it's also important to note that the mandibular incisor crowding is normal as a kiddo when the teeth first come in, but it will typically self-correct itself as the jaw grows a little bit and kind of works into the movement. And there's a lot of shifting and moving of those mandibular incisors as they kind of come in and go into position. The tongue is kind of helping and the lip is kind of helping get everything in there. But when we take a look at everything, it's common for those permanent lower incisors to come in lingual to the primary dentition. That's very common. And they're also a lot larger than the primary teeth. So they're a lot wider. They don't have a lot of space. So they've got to kind of wait for the jaw to grow a little bit. So it's also very common to see a little crowding of those lower incisors when they first come in. It's also very common to see a maxillary midline diastema, and that will tend to go away. Once those maxillary canines come in between 11 and 12, they will come down, and they're such a wide tooth with a really big, strong root. It will kind of naturally close that midline diastema by pushing those 4 central incisors together. Now, like I said about my daughter, the maxillary canine, that tooth is the most likely to be impacted within the bone. And so we have to be careful of that. When we're watching our 10 to 11-year-old kiddos, if there's no sign of it and you can't feel that canine coming down or pushing down or seeing any root resorption there, then you have to keep an eye on that, the possibility that it could be impacted. You want to be able to assess that sequencing of your patient and keep a close eye on that. And really, the Panorex will show and reveal that impacted canine pretty easily. The other thing, I mentioned the leeway space. That's that little extra space that's available because the permanent second molars are a lot wider in a mesial distal direction compared to the permanent premolars. So those smaller permanent premolars, when they come in, that little leeway space allows for the permanent mandibular and maxillary first molars to kind of tuck in and establish that class 1 molar relationship that we're looking to achieve for our patients. So sometimes with our patient, there isn't a leeway space for the eruption of those premolars, and that can sometimes have a problem creating that class 1 ideal occlusion in the permanent dentition if that leeway space is shifted or non-existent. And honestly, if somebody loses those primary mandibular or maxillary second molars early, then that permanent first molar is just going to drift right into that space and sometimes block the eruption of that second premolar entirely. So those are also things that you want to keep a really close eye on as you're kind of doing your evaluation. And there's different phases of orthodontic treatment, and I'm just going to cover these briefly here as we wrap up. So phase 1 is early intervention, and this is happening when we're focusing on the initial skeletal corrections, things like palatal expanders, headgear, functional appliances, space maintainers, and possibly even primary tooth extractions to kind of keep the sequence going in the right direction. And then phase 2 is the corrective phase. And this is when there's active treatment of full ortho in the permanent dentition going on. And honestly, retentive phase is a minimum of 6 months. And that's just to kind of retain all of the hard work that goes on in creating that treatment. So as a dental hygienist, after we've done our assessment and we're evaluating our patient for ortho treatment and they are referred to the orthodontist for treatment, one of the other most really important things for us to do is to consider our oral hygiene and oral health education considerations for those patients, because that will really impact the quality of the end result that this patient gets. Self-care is especially challenging for the adolescent population, as we know. This increases their risk for caries, gingivitis. They have a really hard time. So we need these patients to be on board with understanding that it's a lot more difficult for them to keep the areas clean around those brackets to the gingival margin. So we need to provide a lot of education. Provide those patients with a variety of toothbrush designs, to help remove that plaque and really manage the biofilm. And even use of a power toothbrush is often helpful for patients. The water jet is a lot easier for them than flossing. So whatever you can get to really help your patients stay motivated to kind of keep the biofilm control under control, then they'll have a better result. It's important to tell your patient that mouthwash alone is not suitable for biofilm control, because a lot of your adolescent patients will think that if they use mouthwash, that's enough. We have to use mechanical plaque control combined with some kind of antimicrobial dentifrice or mouth rinse if the patient decides that they like using a mouth rinse. So regular twice a day topical application of a stannous or sodium fluoride, and a rinse is typically recommended because we know that they have an increased caries risk. So for caries risk, a fluoride varnish or a 1.23% APF gel, or even a prescription strength home use 0.5% fluoride gel or paste. Daily use of a 5,000 parts per million fluoride toothpaste is also okay. No matter what you're doing with your patient, if you are providing them with good assessments to do early intervention for ortho, and you're really taking a close look at like all the different parts and pieces that make up that patient that you serve, and then kind of on the back end providing them with the adequate support and educational needs that they have during that orthodontic treatment, it's so vitally important that they're really managing their biofilm while they are in ortho treatment. And the hard part about that is that ortho treatment is usually 18 to 24 months. And so they can kind of fall off the wagon after a while. So it's really important for you to keep them motivated, keep them educated, and kind of keep them kind of engaged in their self-care through the whole process. I hope you guys are having a great week and everything's going well for you in school. Keep up the hard studying and good work working towards your goals. I will see you all next week. Be sure to subscribe to this podcast so that whenever a new episode launches, you will get a notification so that you can take little steps towards learning all that you need to know for dental hygiene school. Take care, everyone.